Namaskar and welcome to the second week of the International Yoga Conference USA 2021. On the International Yoga Month June, the American Academy of Yoga and Meditation, in affiliation with multiple eminent institutions, is organizing the event, the International YogaCon USA 2021. This event offers a global platform to all those who would like to share their knowledge in yoga and its importance in health and wellness, and would be graced by many prominent scientists and physicians of international acclaim in their field. American Academy of Yoga and Meditation, or AAYM as we know it, is a nonprofit organization of physicians, researchers, medical professionals, and practitioners of yoga and meditation. The organization is dedicated to education and research in the field of yoga and meditation by fostering an interdisciplinary approach of linking science, arts, ethics, and spiritualism to improve ways of human life. Conditions like arthritis, migraine, low back pain, and chronic pain can affect mobility and impact the quality of life negatively. Pains like prolonged lower back pain may result in disability presenting challenge in conducting day-to-day activities. While other forms of exercises do help, the issues like stress related to pain and disability may go unaddressed. Originally part of traditional Indian spiritual self care and medical practice, yoga has become a popular practice to promote physical and mental well being and to treat a number of medical conditions, including chronic pain. In this webinar titled Yoga for Chronic Pain, learn from our experts about their research in these fields. The chairperson of this webinar is Dr. Holger Cramer. Dr. Holger Cramer is a research director at the Department of Internal and Integrative Medicine, University of Duisburg-Essen, Germany, and an adjunct professor at the National Center of Naturopathic Medicine, Southern Cross University in Lismore, Australia. Building on his own long-standing yoga and meditation practice, he conducts research on the health benefits of mind-body practices and non-pharmacological integrative health approaches in chronic pain, cancer, internal medicine, and psychiatric conditions. He has published over 200 scientific papers on yoga, meditation, and related methods, and is the editor-in-chief of JACM. In addition to clinical research on the effects of yoga on patient-relevant outcomes, a major focus of his work is public health research on the use and dissemination of mind-body medicine and implications for healthcare systems. Thank you for gracing us with your presence, sir. On the panel today, we have very eminent speakers like Dr. Stephanie Munaz, Dr. Eric Drozel, and Dr. Dennis Dunhire. The American Academy of Yoga and Meditation welcomes you all. I will now hand it over to our chairperson, Dr. Cramer. Over to you, sir.
Thanks a lot for the kind introduction. Good morning, good day, or good evening to everybody, wherever you are in the world. And thanks a lot for joining our session on yoga for chronic pain. We will have about 1 hour and 50 minutes to present you the current research evidence on yoga as a therapeutic intervention for chronic pain, especially focusing on chronic low back pain and arthritis. We have 3 excellent speakers from different continents: Dennis Dunhire from Germany, Dr. Eric Drozel, and Dr. Stephanie Munaz from the USA. And we will start with Dennis Dunhire. Dennis Dunhire is research fellow at the Department of Internal and Integrative Medicine, the Faculty of Medicine at the University of Duisburg-Essen in Germany, where he's part of a very productive research group in integrative medicine and complementary medicine in Germany. And he has gained extensive experience in conducting clinical trials and conducting systematic reviews and meta-analysis. Dennis Dunhire's main area of research are integrative pediatrics, pain disease, mind-body medicine, and research methodology, where he has authored several peer-reviewed articles on yoga, especially for pain and pain-related conditions. And the topic of his talk is yoga and mindfulness for patients with low back pain, results of meta-analysis. Thanks a lot for joining us, Dennis, and the stage is yours.
Thank you, Holger. So I can switch my first slide, I think, and start with my second slide and the roadmap for the next around 15 minutes. First, I would like to give you a little bit of background, and then I go into the methodology that we use to conduct our meta-analysis, followed by the results of our meta-analysis, and I would like to end my presentation with a few concluding words. So here are a little bit of background information, and here we see the impact of chronic and acute low back pain on our healthcare systems. On the left side, we see that musculoskeletal disorders cause about 138 million disability-adjusted life years in 2017. And on the right side, you can see that low back pain alone was responsible for about 2.5% of all disability-adjusted life years in the year 2019. And this ranks it ahead of depression and headaches and lung cancer. As we know, we have few treatment options for back pain, and these includes NSAIDs, for example, which are likewise cause severe side effects. So research into non-pharmacological treatment options is very important. And this naturally include mind-body medicine practices such as yoga and mindfulness-based stress reduction. But what is the rationale behind these procedures? Besides the obvious effects on the muscles and the fascia, there are also stress reduction mechanisms. And the following slide shows in great detail what these mechanisms can look like. And yoga and meditation have a direct effect on the stress response. So this may cause the pain-releasing effects of yoga, and especially for mindfulness-based stress reduction. This is what we have done in our meta-analysis. We included in our meta-analysis only randomized controlled trials, but we made no restrictions regarding publication type. So we also screened like literature, for example, and clinical trials that were not finished at the moment we done our search. We included patients with low back pain, regardless of pain cause, duration, intensity, and radiation pattern, and we made no restrictions in age. What kind of interventions we include in the yoga trial, in the yoga meta-analysis study that compared yoga with no treatment, usual care, other passive treatments, or any active treatments were eligible. And we excluded studies where yoga was not the main intervention and yoga was only part of multimodal intervention. We made no restrictions in the yoga type. We include all yoga types we found. In the mindfulness meta-analysis, we compared MBSR or MBCT studies with no treatment, usual care, or passive treatments, or any active treatments. Studies of mindfulness-based interventions that were clearly different from the MBSR, MBCT programs were excluded, such as ACT or DBT studies. We looked at some outcomes, and we only include studies that assesses pain, back-specific disability, and physical functioning. And I will show you the results of these three outcomes for both interventions for yoga and mindfulness-based stress reductions. This slide is important for the interpretation of the results. Therefore, try to keep this classification in mind. We distinguish between HSG for a small effect if the SMD, the standardized mean difference, is between 0.2 and 0.5. If the SMD is between 0.5 and 0.8, it's a moderate effect, and a large effect is an SMD above 0.8. So try to keep this in mind, because we need this for the interpretation in the next slides. So let's go to the results. First, I'd like to show you the flow charts of the two meta-analyses we've made. And on the left side, you can see the flow chart for the yoga meta-analysis. We found 571 records after we screened PubMed, Cochrane, and Scopus. And we have done a lot of removement, because most of the studies don't fit to our inclusion criteria. I presented some slides before. After that, we found 30 articles on 27 individual trials and included this in the meta-analysis. For mindfulness, we found 211 abstracts after removement of all the trash. There were 8 full texts on 7 studies that we can include in our qualitative analysis, and only 7 full text of 6 studies were included in the meta-analysis. Now we can move through the results, and I try to explain what you can see on this slide, because some of you might not be familiar with the presentation of a meta-analysis, so I try to explain what you can see. Here you can see on the left side of this figure the included studies in the meta-analysis with their data. And the data is split into the experimental group and the control group. And you see the total number of participants in each group. Also the mean of the outcome. Here is its pain. And you see the measure is very different. So some of the trials use numeric rating scales. The other trials use a visual rating scale. So you have some different numbers in this row, and it's followed by their standard deviation. So you can see this for experimental and for the control group. The experimental group is the yoga group. The control group for this case is a passive control. In the middle, you can see what we call a forest plot, and the standardized mean difference is plotted as a box with a line, and the box represents the standardized mean difference, and the line is the 95% confidence interval. You can see that these boxes have different sizes. This represents the weight in which the study is included in the meta-analysis. A small study has a lower weight than a big study. So you can see here a study with 14 participants. This has a very small box, and here a study with nearly 268 participants has a very, very big box. And the red diamonds are the pooled overall effects, the effects that are the results of the pooling of all studies in the meta-analysis. What you can see here is that these diamonds do not cross this line, and this means that we have a significant effect, a significant total effect in favor of yoga compared with a passive control group. And this is not a very small, it's a small effect. It's below the burden of 0.5. If yoga was compared with an active control group, you can see a non-significant effect. If you look upon the random effects model, if you look on the fixed effects model, it's a different measure form. It's a significant effect. For this meta-analysis, I'd like to prefer to interpret the random effects model result. And on this side, you can see the results for the passive control. Yoga was passive control at long term. It's also a significant small effect. And if compared to an active control, it's a non-significant effect. This is the result for the mindfulness-based stress reduction meta-analysis on pain. Here you can see also a significant small effect for mindfulness-based stress reduction if compared to usual care at short term. If you compare mindfulness-based stress reduction to an active comparator, it's non-significant. Also, all the long-term effects are non-significant for the pain outcome. For pain-related disability, here are the results for the yoga meta-analysis. Also, you can see a significant small effect if compared to passive control at short term. And you can see a significant small effect if you compare yoga to an active control group at short term, and also a significant small effect if you compare yoga to a passive control group at long term, but not if you compare yoga to an active control group. For mindfulness, you can see a non-significant effect if mindfulness was compared to usual care short term. Also, also compared with an active comparator, and the long-term effects also were not non-significant for mindfulness-based stress reduction in the pain-related disability outcome. Last outcome, physical functioning. Here is the yoga group on the right side, not on the left side. And you can see also a small effect for yoga in favor, if you can compare yoga to a passive control group at short term. We also see a significant effect if you look at the fixed effects model, but not in the random effects model, if yoga was compared to an active control group at short term. And we also see a significant small effect at long term if compared to passive control. And if you compare yoga to an active control at long term, it was not significant. For mindfulness, only the comparison to a usual care group at short term was significant. A comparison to an active comparator at short term, and also the long-term effect were not significant in these meta-analyses. What can we conclude? We can conclude that we can see comparable effects versus passive controls at short term, but we also can see that yoga seems more sustainable at long term. And compared with an active control, yoga seems more effective than MBSR interventions. Perhaps you can ask if this is a reason to conduct a study of yoga versus versus an MBSR. So you have a direct comparison between active mindfulness and mind-body therapy versus an somewhat like passive mindfulness-based therapy. At this point, I'm at the end of my presentation, and I would like to thank you for the attention.
Thanks a lot, Dennis, for sharing your fascinating research findings. And if everyone from the audience has a question to Dennis or to the other presenters later on, please write a WhatsApp or an email to the number or email address displayed at the banner of the bottom of this screen. Thanks a lot, Dennis. Our next speaker is Dr. Eric Gressel. And Dr. Gressel is professor at the Herbert Wertheim School of Public Health at the University of California, San Diego. And he's director of the UCSD Health Services Research Center. He's also a principal investigator and health services researcher at the VA San Diego Medical Center. And Dr. Gressel received his PhD in clinical psychology in 1999. His NIH and VA-funded research primarily focuses on the benefits of yoga intervention in chronic pain populations, military personnel, and veterans, and in older adults. He also studies measurements and mechanisms of change in yoga research. Other research interests include broader integrative health, cost effectiveness, and health economics research, behavioral interventions, and patient self-management. And Dr. Gressel will also speak on yoga for low back pain, but especially in veterans. Thanks for joining, Eric. Please.
Great. Thanks, Holger. And hello to everyone out there. Good morning from San Diego. I'm going to share my screen now. Let's see. Is that coming through, Holger?
See anything currently? I currently can't see the presentation, sorry.
Okay. Let me try that once again. There it is.
Now we see it.
Okay, great. Well, in the interest of time, I will get started here. I wanted to quickly acknowledge all the great staff and help I had in completing this research. So as far as military veterans, we know that from the research that they experience higher rates of chronic pain, and the pain often tends to be more severe. So here on the graph, we see that a sample of veterans, 58% reported chronic back pain, and that was the leading type of chronic pain reported. We also know that pain medication in the VA system, so the Veterans Affairs is the healthcare system where many veterans, I should say, receive healthcare. Pain medications such as opioids were often the primary treatment, even though we now know that they are often ineffective and have very serious side effects, addiction and overdose. So as far as the evidence on, Dennis presented a little bit of the evidence, some of these same studies, but in 2011, 2 large randomized trials of yoga for chronic low back pain were published. Karen Sherman's study found that the yoga group, compared to self-care, had reductions in pain and medication use. The Tilbrook study out of the UK found that yoga had was significantly better at reducing disability compared to self-care. However, for a number of reasons, these were conducted in community settings, so they were mostly women, and it was potentially hard to generalize whether these same results would be found in military populations. So the veterans served in the VA are 90% men, approximately. That keeps changing with more women serving in the military. They tend to have fewer economic resources overall. Those are veterans served in the VA. They have more substance use on average than veterans not in the VA, and more physical and psychological comorbid conditions overall. So worse health overall on average. We've also done some research that shows there is some stigma towards yoga in military populations, where it's seen as being for young and flexible people. Maybe it's more for women and not men. So we want to overcome some of that. And after doing some pilot work, we were funded to do a randomized trial in which we randomized 150 VA patients to either yoga or a delayed treatment control. And so the delayed treatment, they got the yoga after waiting 6 months, the same program. This is Hatha Yoga with lots of modifications. We want to make it safe and available to all people. We had a few criteria. people with some severe conditions that were not included, I should say. This was twice weekly yoga, 60-minute sessions, in-person sessions. We also strongly recommended regular home practice, so 15 to 20 minutes on a daily basis at home, or more if they were able. And here are the research assessments as shown. I wanted to say a little bit more about the type of yoga we use in this study. So in looking at Patanjali's 8 limbs of yoga, a lot of the yoga, hatha yoga in the US and in our study focuses mostly on limbs 3 and 4, the poses and the breath, but there are definitely elements of concentration and meditation involved in our study. We touch a little bit on some of the yamas and niyamas, but that's not a major focus, I would say. So here's just a quick photo of some of our veterans doing yoga at the VA. And we let them use a chair, especially early on, to help with balance and safety if they would like. So as far as our results, we published these results a few years ago. We found that there were no significant adverse events, so no one was injured despite having long-term chronic low back pain. The yoga group had significantly larger improvements in back pain-related disability, as well as other outcomes such as pain, fatigue, and quality of life. So we had these, the decreases in pain and disability were moderate, I would say. I think they were effect sizes around 0.4 to 0.47, so small to moderate in Dennis's presentation. But we achieved these despite lower than optimal attendance. We also had, a more impaired population than in previous studies as far as other physical health conditions. And we also, the sample as a whole, decreased their opiate use and decreased their use of other pain treatments. So some were actually coming off of these medications, and yet pain decreased. I just wanted to show a graph. The dotted line here is the yoga group, where we had a steady decrease in pain in the yoga group, whereas the control group stayed fairly even over time. And those effects were maintained out to 6 months for the most part. In this slide, I just want to focus on this first line mostly. In opioid pain medications, there were no significant differences between the two groups. However, the sample as a whole went from 20% using opioid pain medications on a regular basis, daily basis, down to 8%. We also had some decreases in other medical treatments for pain and self-help pain treatments. I think that my slide is a little bit cut off here, but there were significant decreases for the whole sample in all 3 areas. So I think what that says is that people enrolling in this study, things they were doing were not working, and the opioids definitely were not working. They were looking for something else, and they were happy to receive yoga. In comparing our characteristics of our sample to those previous large trials of yoga for chronic low back pain, we do see that our study was a little bit older, 5 to 7 years older. We had 25% women as opposed to 2/3. Our sample was about 51% non-white, meaning more ethnically and racially diverse. A little bit less educated. More notable is much higher unemployment, and 18% of our sample had been homeless in the last 5 years. And these other studies, they didn't even report data like this. I don't know if they didn't measure it, probably not. When doing research in the community, not a lot of that research enrolls people who have been homeless or are homeless. Back pain duration was 15 years versus 10 or 11 in these other studies. And the RMDQ, which is disability level, was a little bit higher. And again, narcotic medication, triple that in the Sherman study, not reported in Tilbrook. And finally, I'm not able to see the attendance rates, but our attendance rates was down around 53%. We offer twice weekly yoga, and that's better. So it was lower attendance. Our veterans have more transportation issues. Many take public transportation and struggled with that. So I just wanted to take one quick look here at the RMDQ, which is disability. A clinically significant improvement is defined as a 30% decrease in the disability score. And if you look at the control group, what happens in the control group in these different studies? In Sherman's study, the self-care group, 55% had a clinical improvement at 6 months. In the Shirkin study of MBSR, this is published in JAMA, very nice study, 44%. In our sample, 24% of usual care had a clinical improvement. And so I think this just speaks to the fact that our veterans have fairly treatment-resistant types of chronic low back pain. So it's a tough group to, yet we, on the positive side, we had a very nice finding of 57% in the yoga group met this outcome. We also did a cost effectiveness analysis, and I'm not going to go into the detail on that. I just wanted to mention that for those who are interested. We published this last year in the journal Medical Care. Real briefly, this slide does a hypothetical comparison of group yoga to individual physical therapy, 8 sessions, which is a full course, which would cost about $600 per person, whereas yoga in the group format would likely cost closer to $100, so 1/6 of the cost. And I should say, work by Rob Saper has showed that yoga and physical therapy produce fairly similar results, at least in that one study. So I did want to mention a couple current studies real quickly, just a couple slides. The Scepter study is a large national study being conducted in the VA at 20 sites. They're planning to enroll over 2,500 veterans. So it'll be a huge study, a huge treatment study. They'll have moderate to severe back pain, and the whole study will last 6 years. This is the study design. So it's not just about yoga. It's about usual care and the standard of care for chronic low back pain. And it's a smart design. So in phase 1, participants are randomized to either usual pain care, often medications and just self-care advice, or physical therapy enhanced with exercise, or they'll be randomized to internet-based self-management of pain. Anyone who does not respond after 3 months will be re-randomized to either CBT, spinal manipulation therapy or chiropractic, or yoga. And then outcomes will be measured up to 12 months. So that's an interesting study to look for in a few years. One other current study I have going on is yoga plus mantra repetition for chronic pain and PTSD. We are including people with chronic back pain and chronic neck pain. And the idea is that veterans with PTSD are even more likely to have chronic pain and have problems with opioid medications. We know from the literature that mind-body interventions can help with both chronic pain and PTSD symptoms. And a mantra repetition, many may be familiar with this, but participants choose a spiritual or meaningful phrase to repeat regularly to themselves. And they practice this, and it becomes a habit, a calming habit. So the idea was that adding the mantra repetition to yoga provides this portable tool. It's something they can do anywhere. Now, you might say, well, they could do deep breathing anywhere, but this is even more discreet. If you're in a grocery store, on a bus, with other people, repeating one's mantra to keep calm when agitated can be very helpful. So we're doing a small feasibility study with 32 participants, randomized to either yoga plus MR or to relaxation. We'll look at outcomes at 12 weeks. And I can report that despite some significant delays because of the COVID pandemic in the last year, our first cohort has been randomized and is attending in-person yoga. They're wearing masks and things are going well. We found that veterans were really wanting to get out of their apartments. Many of them live alone and were really wanting something in person, even though there's lots of online programs available these days. So in summary, overall, we know that yoga is now an evidence-based treatment for chronic low back pain. This is citing an important article to this effect. Our results show that yoga is effective and cost-effective as an option for veterans with chronic low back pain. I think going forward, we need more work to spread the availability of yoga for veterans with chronic low back pain, make it more available, and encourage them to practice this. Thank you.
Thanks so much, Eric, for sharing your study results. It's really important to see yoga for special populations, but also to see such cost-effectiveness studies. These are extremely important to really bring yoga into the healthcare system. Thanks so much.
Thank you.
We will now switch to our last speaker, and we'll also switch from low back pain to other chronic pain conditions, especially arthritis. Our next speaker is Dr. Stephanie Muniz. And Stephanie Muniz serves as a chair of integrative health research at the Maryland University of Integrative Health. The research focuses on the effects of yoga for arthritis and for chronic pain. Along with research collaboration with the National Institutes of Health, Einstein Scenery, and Montefiore Hospitals in New York, National University of Natural Medicine, and University of Maryland, Dr. Muniz works to bring yoga to people with arthritis in communities around the US, as well as educating yoga teachers and yoga therapists about the unique needs of this population. She contributed numerous peer-reviewed research articles, as well as book chapters related to this focus, and her book, Yoga Therapy for Arthritis, A Whole Person Approach to Movement and Lifestyle, was published by Singing Dragon Press. She also serves as a member of the board of the Executive Committee for the Academic Collaboration for Integrative Health, which advocates for enhancing research, education, and clinical care across integrative health fields. And Dr. Muniz's talk will focus on the management of arthritis and chronic pain with yoga. We're looking forward to that, Stephanie.
Thank you so much, Holger. I'm sharing my screen now and switching over to my slides, which hopefully you can see. Okay, confirm that you're seeing this, Holger?
I can't, unfortunately.
Really?
Oh, now it's there.
Okay, all right, there's just a little lag. Wonderful. Okay, pleasure to be here. So I first want to clarify that when I'm talking about arthritis, it's not a single diagnosis. Arthritis, which means at its root, inflammation of the joints, includes over 100 different conditions that share some features, including a lot of common symptoms, but have a variety of different mechanisms. Arthritis as a whole is the leading cause of disability, and osteoarthritis, which I'm going to be talking about, is the most common. But then there are also a whole host of systemic inflammatory arthritis conditions, such as rheumatoid arthritis, which I'll also be mentioning. It can actually impact any age group. It tends to be more common as people get older because of osteoarthritis's prevalence. And many of the common features are pain, swelling, stiffness, and fatigue, in some conditions even affecting other organs. People may have more than one form of arthritis at the same time. And none of these conditions have a cure, but there are a variety of pharmacological and non-pharmacological management strategies, including yoga. Now, when I talk about yoga, I don't mean only the postures and the breathing practices, which especially in the West tend to be most utilized, but I'm talking about a variety of yoga practices, each of which has a slightly different mechanistic potential for its impact on life with arthritis. Arthritis affects the whole life of the person who has it, and yoga can intervene on a variety of levels. I'm going to give you with a little bit of the theoretical rationale for why yoga could be beneficial for this population. Of course, movement is recommended for arthritis management across all forms of arthritis. It's low impact. It can be adapted to any person's individual movement abilities and limitations. It includes a variety of different components of physical fitness, and there's evidence that it is enjoyable to people and accessible. They also may have greater fitness, which can improve their activities of daily living, and reduce disability, because arthritis is the leading cause of disability. And all of these references will be provided at the end. From the breathing practices side, when people are in pain, they may not breathe fully and deeply, which is also associated with the stress response. So taking deep breaths engages the relaxation response in the nervous system, which is tied to pain processing. Also, when people are breathing more deeply during exercise, it ensures that they're not moving into an anaerobic state, which can be associated with muscle soreness. And breathing practices are a common way for people to manage daily life challenges. Meditation can help people living with arthritis to focus on the present moment and not be so concerned with what has already happened or what's yet to come. It helps them to be more aware of what's going on in their own bodies and therefore make better choices about how to manage their arthritis as their symptoms change. It also changes the composition of the brain, especially in the areas of pain processing and its emotional component. And it can help people to take a moment to pause and make a choice about how they want to respond to a situation, especially with regard to how they manage their pain. When it comes to the philosophy, yoga philosophy can help people have a different relationship to their disease, focusing again on the present moment, but also noticing negative thoughts when they arise and replacing them with positive ones, not getting so tied up in the disease as a core component of their identity, focusing on not harming themselves and others with how they choose to respond to their pain and its effect on their lives, and having some reflection on that process, that experience, so it might even lead to some wisdom as a result. So I want to show this because it demonstrates how much yoga research in general has grown. This is actually looking at publications of yoga as a therapy, therapeutic yoga. And while it's a few years old at this point, you can see that there's a giant up curve in recent years in terms of just the volume of yoga research, and especially the higher methodological quality research. So it's only in recent decades that we've really seen a robust growth in the yoga research literature. For yoga that is that is offered to arthritic populations in particular, this is what it looks like. So you can see if we're going from left to right, there's a giant increase in the volume of research that has been produced since 2010 as compared to before that. And especially when it comes to an increase in reviews and clinical trials. Now we compare that to something that's a lot better studied, like for example, the DASH diet, which is a low sodium diet for people with hypertension. So if we're looking at all of the studies published on yoga for arthritis in recent years, there are 115 publications altogether. And we look at a low sodium diet for hypertension, and there are almost tenfold the number of publications. So we still have a long way to go for this literature to be robust and well established. Most important, we want to look at, is yoga safe for people with arthritis? And I think that these two studies are really fascinating to look at side by side. Both of them happen to have Dr. Cramer as first author. Now, this is not a direct comparison between yoga in randomized controlled trials and yoga in epidemiological studies, but I think looking at the two side by side is really telling. What it shows is that the yoga that happens in the context of randomized controlled trials tends to be quite safe. And in fact, they conclude that yoga appears to be as safe as usual care and exercise, the groups that yoga tends to be compared to. However, when we look at epidemiological studies, which is people seeking yoga out in their communities rather than yoga research studies that are designed specifically for the population that they're serving, there do tend to be some risks. A considerable proportion of yoga practitioners experience injuries or other adverse events. So this suggests that the yoga that's happening in randomized controlled trials, where the yoga is designed for the population at hand, may be safer than yoga that is available out in the community. Again, it's not a direct comparison, so we have to be careful about the conclusions that we make based on this. Now, I'm going to talk about findings from a randomized controlled trial that we conducted at Johns Hopkins University for people living with rheumatoid arthritis and osteoarthritis. It included a comprehensive yoga program over 8 weeks for adults with arthritis who were ambulatory and had mild to moderate arthritis. What I want to point out here is something about the feasibility. You can see here that of the 75 people who were enrolled in this trial, 20 of them enrolled for the study and did baseline testing, but did not come to any classes, never came to a single class. For the people who did come to a class, the vast majority of them attended most classes, with most people missing just a couple of classes for one reason or another. So I was interested in who are these 20 people and how might they be different from people who tended to come to most of the classes. And it turns out that there are 3 characteristics that differ by attendance: age, race, and flexibility. And in thinking about how yoga is represented, at least in the West, it tends to be, as was said earlier, younger, more physically fit persons, and especially white women. And so people who are older, who are of a minority race, who are less flexible, may feel as though yoga is not for them. They may feel self-conscious about starting a yoga program. And what the evidence showed is that most people who came at least once felt comfortable enough with it to continue, but it's getting over that barrier of coming in the first place. We then decided to conduct a study through NIH, specifically gearing that same yoga intervention toward underserved minorities, which included African Americans and Spanish speakers. And so this was a much smaller study, but the classes were all bilingual and it used the same protocol. And what we saw was it was very challenging to get enough participants to complete the study. We started out screening 128, and in the end, I don't know if you can see this at the bottom, but there were 12 people who completed the full intervention. So that's very different from what happened in the Johns Hopkins study that was not geared toward underserved minorities, and we easily recruited 75 participants. Now, there is evidence that yoga is feasible, and there are a variety of studies that demonstrate retention rates of 95 to 100%, but those may not be looking at the role of underserved minorities and how accessible yoga is to those populations. Now, when we look at the effectiveness of yoga, especially for markers of physical fitness, we see that there are improvements in people's rating of their overall fitness, as well as measures of their fitness, especially including flexibility and mobility. In this particular study, the balance measure had, by random chance, a difference between groups at baseline. So while the yoga group improved more than the waitlist group, the difference was not statistically significant after 8 weeks. In the NIH study, even though the sample size was relatively small, we also saw improvements in physical fitness here. In this case, improvements in balance and in flexibility again, as well as in disability of the arm, shoulder, and hand, which was not measured in the Hopkins study. When it comes to patient-reported outcomes, what people say about their own health, we saw a statistically significant difference between groups in depressive symptoms, positive affect, pain, physical roles, energy, general health, and mental health, but not for negative affect, perceived stress, which was surprising to us, arthritis self-efficacy, and social and emotional function. We do hypothesize that the people enrolled in the study were doing relatively well socially and emotionally at enrollment, so there was less room for improvement. And these changes either persisted or were strengthened from the end of the 8 weeks until 9-month follow-up. So they continued to get better over time, even after the yoga classes ended, mostly continuing the yoga on their own. Now, when we look at a meta-analysis that was conducted just on people with osteoarthritis, including 9 trials of mostly older women, which is appropriate for this population, and especially those from this population that practice yoga, there were statistically significant improvements for pain, physical function, and stiffness, but not for quality of life, depression, or for those who had hand osteoarthritis. The majority of the studies here were in the knees. Unfortunately, they were of low methodological quality, and the safety was rarely reported. In a meta-analysis of rheumatoid arthritis only, including 10 trials of mostly women, you can see rheumatoid arthritis tends to affect people younger than osteoarthritis does. Here, there were statistically significant improvements for physical function, disease activity, and grip strength, but not for pain, tender and swollen joint count, or inflammatory cytokines. Again, they reported low methodological quality and sample sizes. And in this meta-analysis, the groups did not have any active comparison group. The studies didn't have an active comparison group. So there was a difference in attention that the people in the yoga arms were getting compared to the comparison arm. And that's important to consider. Some conclusions we can draw from this research are that there's a strong mechanistic rationale for yoga in arthritis management, and the existing evidence is promising, but the studies are small. There still aren't enough of them. Many of them have low methodological quality and insufficient reporting, but yoga does appear to be safe from the data that we have, and especially in therapeutically oriented randomized controlled trials. Maybe that doesn't hold up in community settings where it's possible that arthritis isn't as safe. And it's important to note that people in marginalized communities, those of older age, minority race, or reduced physical ability, may feel as though yoga is less available or acceptable or accessible to them than it is for other people. We do need more research on yoga for arthritis that has stronger methodological quality, active comparison groups, and pragmatic design so we can better understand what's happening in yoga the way that it's offered out in the world and make recommendations accordingly. From a clinical perspective, I recommend, based on what we know so far, that people living with arthritis really seek out qualified instructors who are trained and have experience working with arthritis, chronic pain, and movement limitations, that they speak with a healthcare provider before pursuing yoga about what particular recommendations might be for them and what they should be careful of or avoid. I recommend starting with live instruction in small classes where a student can get individualized feedback and recommendations rather than going on YouTube and using a recording to practice yoga, which may be a viable strategy for ongoing yoga practice once getting some individualized care. I also recommend that a yoga practice include not just the postures, but also breath, movement, meditation, and philosophy, which may have different mechanisms for providing benefit for people living with arthritis. It's important that we look at what barriers might exist to access and acceptance of yoga for marginalized and intersectional communities, so people who are living with a chronic condition, but also feel marginalized based on their identity in another way. And for people with arthritis practicing yoga, it's important to build a self-awareness to understand what's happening in their own body and what feels okay or not okay, but also feeling empowered to be able to make individualized choices based on what they're experiencing and pursue an individualized approach rather than feeling the need to mimic an instructor or follow recommendations that don't feel right in one's own body. I also recommend starting slowly and noticing how one feels perhaps the next day, the next couple of days before engaging in a more challenging physical yoga practice, and also establishing social support to stay consistent and accountable with ongoing practice. These are the references that I mentioned at the beginning for the mechanisms by which yoga may be beneficial for people with arthritis. Thank you very much.
Thanks a lot for this fantastic talk, Stephanie. I think it's great to see more and more research being done, not only in the general population of patients, but also with special groups like Eric did with veterans and you, and also other researchers with minorities, because we see they're not all the same and everybody have different needs and different approaches. So this is a great step advancing yoga research. I also really like that you pointed to the shortcomings that yoga research still have. So we have a great evidence out there, but there's still a way to go. And we have some time for questions. We have 15 minutes left. So I would like to open up to the panel. And so far, we mainly have questions on yoga practice, not so much on yoga research. So I'm really glad to have Stephanie here, who is absolutely expert in yoga therapy. So I would like to direct the first question to you, Stephanie. And this is someone who asked to suggest yoga and mindfulness practices for SLTV, which I just had to Google, and I think it's lumbosacral transitional vertebrae.
Yeah, and actually, I'd be interested to hear from Dennis and Eric about whether or not they've seen this in their research, because my understanding is that what we tend to see from a research perspective is chronic low back pain that does not necessarily have a well understood etiology, or chronic low back pain all inclusive, where a study may be looking at lots of different mechanisms for that low back pain, both physiological and psychological. And so there's an opportunity for yoga to intervene on a variety of levels, regardless of the diagnosis. So I can speak to it therapeutically, but I'd first like to know if you know anything about this from an evidence-based perspective.
Well, I can offer that. I don't know anything about that specific condition. I think in our research, we get our veterans, certainly with low back pain, have a lot of different conditions, hips and knees and SI joints, and they have neck, mid back, and low back issues. So it's hard to say. People are trying in some of the new studies out of the Backpack Initiative, I think it's called, and NIH, to look at really large samples, maybe 1,000 or more people, and give them treatments and really try and classify the different subtypes of back pain. But that research or that evidence is not out yet. So.
Yeah, I totally agree.
Okay, so I can say, first of all, I want to say that my expertise is in arthritis, but I will say that for spinal conditions, and especially like this one where there are fusions in the vertebrae, yoga practices can be exacerbating of that pain, because when you have vertebrae that are fused, there tends to be a compensation for that fusion above and below, or in this case, it's only above. But you tend to get a lot of pressure on the joint directly above that in order to compensate for that fusion. So one thing that I recommend is listening to your body. And when you feel an increase in pain, I don't say no pain, because many people living with these conditions are experiencing pain all the time. But if a yoga practice is exacerbating pain, back away from it. I tend to, for conditions like this, not go to the full range of motion, but take the movement in the direction of the full range, backing away from going all the way to the extreme, and especially adjusting the movement if you're noticing anything sharp or shooting. The sensation that you're feeling in yoga practice should be a dull ache in the belly of the muscle. So anything that's in the joint or that's sharping, shooting, you want to try to avoid. For pain conditions in general, leaning more heavily on the non-physical practices, certainly adapting the physical postures to avoid exacerbating pain, but especially practices like deep breathing that extends the exhale and calms the nervous system, and visualization that allows the muscles surrounding the area of pain to soften and relax, especially in a safe and comfortable position, can be really helpful regardless of the diagnosis.
I would just quickly add that we did a study comparing restorative yoga, which is very relaxing and almost no movement, to hatha yoga in chronic low back and neck pain, and found busy people working that had families preferred the restorative type of yoga, which was all focused on some meditation and the breath.
Okay, great. Thanks a lot. The next question also is a more clinical one. And one participant is telling that they have been taking ibuprofen for the pain in their shoulder and sternoclavicular joint, but it is not helping. And they are asking for an exercise for this. I think it's the same here as with LSTV, that there is not much research into this. There is some research on yoga in the neck and shoulder area. We have done some research in that, and it's by far not as advanced as it is for low back pain. It's much less research, but there are first good hints that yoga can be helping with neck and shoulder pain, but especially on shoulder pain and especially on sternoclavicular joint, I'm not aware of any studies that are really pointing on evidence of effectiveness. So I would again handle this over to you, Stephanie, for the therapeutic part, but open up then to the panel for research on that.
Yeah, so we have seen, when we're talking about use of over-the-counter pain medications, while it's not effective for this participant, I will say that there is some research suggesting that when people with chronic pain practice yoga, there may be a reduction in their reliance on pain medications and maybe a reduction in the dose or the frequency of pain medications. For the shoulder in particular, there are a lot of movements in yoga that take the arms up over the head. And those can be really either difficult, painful, or unavailable entirely to people who have some kind of shoulder pathology. There are lots of ways that those postures can be modified. So one is that you can put your hands on your hips instead of up alongside your ears, or put your fingertips on your shoulders, or come into a cactus sort of position, or take the arms out to the side as a variation, and holding the arms up in a position that is comfortable and not exacerbating can help to build some of those stabilizing muscles that can help keep the shoulder joint from moving around, creating a lot of friction and pain. If the participant, if the questioner is not experiencing relief from their pain medication use, I do recommend that they see their medical provider, and perhaps there is a physical therapy or physiotherapy regimen that would be recommended. What we often do is what we call yogification of physical therapy. So we take whatever the physical therapy prescription is and add mindfulness to it, add slow, steady movements, coordinate the breath with the movement. So take that recommendation from a musculoskeletal perspective and add many of the other aspects of yoga that might enhance the benefits for pain management.
Yeah, I agree with Stephanie and don't have much to add, actually, except that everybody's different. And I think it is important to see somebody live, a yoga therapist or expert that could, observe and see when and where the pain is occurring. We are seeing a lot of people that are having shoulder and neck problems in the pandemic, being at home and using the computer and the mouse a lot. And certainly there can be some changes there that people try that help too.
Okay, thanks a lot. So I don't see any further questions. Perhaps I might ask the organizers, is there any more? Okay. There's another question just coming out in. And the question is, if I got it correctly, is how much inflammation contributes in cold shoulder. So this is more or less in the same direction. It's also asking for shoulder pain and how much inflammation is contributing to cold shoulder. I'm not sure, Stephanie or Eric or Dennis, if you can say anything on that.
I mean, so the questioner is asking about the breath, and absolutely. I mean, I think that first of all, most of us are not breathing fully and deeply most of the time, and especially people who are in pain. You know, one of the ways that we cope with pain is to shallow the breath, because sometimes taking deep breaths can actually expand the torso and can move the musculoskeletal system in a way that is painful. Anyone who has had an injury might have experienced that when they took deep breaths, it could be painful. And so it's important to be aware of that and not breathe in such a way that it exacerbates pain, but also not make the breath any more shallow than it has to be, because that also turns on the stress response, and there is a loop between stress and pain. So this is a really complex consideration. Sometimes if breathing deeply is painful, you can find a different position of the body. So if being upright and taking deep breaths hurts the shoulder, then sometimes laying down, and this is where restorative yoga practices can be really useful, laying down either, partly or supported by bolsters, or, with some support under the low back, with the knees up on a chair, that sort of thing, might be able to take gravity out of the equation, change the where the pressure is in the torso, and therefore make it more possible to take deep breaths and calm the nervous system while being a little bit more comfortable. In terms of the contribution of inflammation, so inflammation, there's not great research on the role of yoga in reducing inflammatory markers. There are some studies that suggest that yoga can reduce inflammation, but not enough studies have looked at it, and it's not comprehensive. But inflammation is definitely a part of this really complex system that includes stress, that includes pain, that includes probably fear. And so if we can do things that are going to optimize our health and well-being and reduce disease activity, reduce overall inflammation in the system, there's a chance that we might be able to intervene on the pain processes as well. But it's difficult to say. We don't have conclusive evidence about that.
Yeah, I would just add that in my experience, what we call frozen shoulder, and maybe that's the same as cold shoulder, results from not moving and using the shoulder, which is usually a result of pain. And most joint pain is the result of inflammation of different types, whether it's the tendons or the joint itself. So, I'm not a physician, but I think it's very important to have that diagnosed, see an expert, and start to move it in a safe way. But the breath also is very important for dealing with it and relaxing the tension, as Stephanie was getting at.
I want to add something else to this that's a little bit tangential, but chronic pain and acute pain are very different. And the longer someone is in pain, the less it may be linked to the actual tissue damage in the body, and the more there start to be many more complex features in pain processing, including psychosocial components, including how we're interpreting the pain, what we think about it, what we worry about, the stories that we have about how this happened or why it happened or what's going to happen. And I think that this is an opportunity not only to continue to use the breath to help manage pain, but also to use yoga philosophy and mindfulness practices, mental practices, concentration practices that help us get out of that loop of, I'm feeling something in my shoulder. What's happening in my shoulder? I'm worried about what's happening in my shoulder. Why did I do that? What's it going to mean? I'm not going to be able to do this. And all of that rumination can actually be a part of the pain process itself. So through yoga practices, we have the opportunity to intervene on a mental level as well, which might actually impact the experience of pain.
Fantastic. Thanks a lot. I think it's really important to highlight this difference and so different approaches we have there. So we need to come to an end, unfortunately, although I could go on for hours with that, especially with those fascinating speakers. But what we saw is that yoga obviously is an evidence-based therapeutic intervention for a variety of chronic pain conditions. The general population, but also in veterans and in minorities. Yoga also is cost-effective and relatively safe in these patient populations. And as such, yoga can perhaps serve as an addition or even an alternative to other approaches for chronic pain conditions. And it's good to have choices because not all patients are the same, as we saw in the talks. So given the huge personal socioeconomic burden of chronic pain, especially in light of the opioid crisis and the high level of medication misuse worldwide, such safe non-pharmacological approaches are urgently needed. Even more so given that yoga can also ameliorate comorbid conditions of chronic pain, such as mental health issues, as we saw. So I think it's good to see such research, and we also saw from the talks that more research is needed, especially outside of chronic pain, but also for other pain conditions. And I would like to really thank the presenters and to the audience for sharing the goal of advancing the evidence base for effectiveness and cost effectiveness for yoga to ameliorate pain in patients in the general population. And I would also like to thank the audience for being here and AAYM for organizing this really important event and for sharing a platform to present all these great research findings. And I think there are some announcements to be made before we end the session.
Thank you so much. I would like to thank Dr. Holger Cramer for chairing this session so well. And we are so grateful and privileged to all of you, Dr. Eric Rotzel, Dr. Stephanie Bunaz, and Dr. Dennis Anheier also for presenting. And we hope to see you again for another really informative session like this. And I would also like to thank our technical team for pulling off such a wonderful webinar. Thank you, Chaitanya ji. Thank you, Siddharth ji. And as for our viewers, thank you so much for joining us today. And we are hoping that you will keep supporting us like this. Along with that, I would also like to inform you that all our information, all the programs' informations are available in our website, www.aaymonline.org. You can log in there for more information and to register for the yoga sessions being held every weekend. Please stay tuned while we come up with our next meditation workshop by Dr. Indranil Basurya, which is going to be held on 13th June, 6 to 7 a.m. IST, which will be 7:30 p.m. to 8:30 p.m. on 12th of June CST. So thank you so much for joining us today. Keep watching us. Thank you. Namaskar.